Hi, everyone. This is Caroline from Fiat Integrative Health in Franklin, Tennessee, and you're listening to the Fiat Health Podcast. We believe that now more than ever, the healthcare industry has become a place of confusion. And over the years, we have been asked countless questions about what true health and integration for the whole person looks like. Join us every other week as we explore topics ranging from primary care and women's health to counseling and spiritual health. We're so glad you're here.
Hi, Amanda.
Hi, Maddie. How's it going?
It's going well. So tell me about yourself and why'd you get into healthcare? How'd you get into healthcare?
So I'm from St. Louis, Missouri. I have been a nurse practitioner for about 10 years, and I've been working in healthcare since I was a teenager. Originally, I was a music major, and I was working at a church. And I was starting to find the music program not meeting my expectations. I wasn't getting a whole lot of personal growth out of it. And I really didn't want to practice anymore. And I thought, if this is how I feel my freshman year, how am I going to do in the future? And so I was talking to a friend as I was doing some soul searching. And she said, well, what's your purpose? Like, what do you want to do in life? And I thought, well, my favorite days are the days that the church members stop by and talk to me while I'm practicing, and I actually get to get involved in their lives and help them with their problems. And so I started thinking about healthcare. And within a weekend, I had changed my major to nursing and started the program after that, and have just worked in a lot of different areas: nursing home, patient care, medical floor, pediatrics, travel nursing, NICU, the ER, all sorts of things, until I went back to school and became a nurse practitioner about 10 years ago and started doing family practice in women's health.
Awesome.
How about you?
So, I'm originally from Cincinnati, Ohio, and, everyone in my immediate family is in the healthcare world in some way. So growing up, that was, the conversation around the dinner table was very healthcare oriented and really what I was exposed to. And I really enjoyed that. And I saw, how meaningful it was to my family members. And so when I applied to college, I applied pre-med, mostly because I didn't know at all what I wanted to do. So my first semester of college, I took a film course and I took chemistry. And film was a lot more fun and chemistry was hard. So I actually switched my major to film and kind of went down that path for a while. Moved out to LA for a summer, and that wasn't it. I just felt like that's not where I was called to be, not where I felt fulfilled. So I went back to the drawing board and started shadowing, spending more time. My sister was an ER nurse at the time, an ICU nurse at the time. Talked to her a lot, spent time in different healthcare settings, and found out that Vanderbilt had a nurse practitioner program where I was a undergrad student at the time. So applied, directly into that program and became a nurse practitioner and never really looked back.
Awesome. That's amazing. And tell me what kind of women's health you do and what your general approach to it is.
So right now, I'm kind of blending both primary care with women's health. I have a huge passion for women's health. My background and kind of experience, you and I are both nurse practitioners, and then you have experience with NAPRO, which we'll definitely get into. And then I have more experience with program organization called FEMM, which is both of NAPRO and FEMM. I'm sure you can also explain this, but they both have really a root cause approach to reproductive restorative medicine. So yeah, I think I'll let you start with, I know you explained it so well. So tell me about NAPRO, and then I'll kind of bounce off of you and explain FEMM as well.
Absolutely. So NAPRO technology is root cause restorative reproductive medicine. It is a form of women's health with about 40 years of research behind it that gets at the root cause of women's health issues without the use of contraception or birth control pills. Every hormone that is given is bioidentical, and the methods in NAPRO are meant to restore the woman's health so that her body can function optimally the way it was intended. So NAPRO is based at the St. Paul VI Institute in Omaha, Nebraska, and we treat all sorts of different women's health conditions, pretty much anyone you can name, from PCOS, endometriosis, recurrent pregnancy loss, pregnancy management, postpartum depression, thyroid disorders, you name it. If it is a women's health condition, it can be treated by NAPRO. And that's kind of the general approach. And then the NAPRO program itself is coupled with Creighton model education. And Creighton model is a type of natural family planning that is used as a natural biological tracker for the women that we see in NAPRO, helping. It's a cervical mucus charting method so that we can track cycles and get a good idea of what's going on with the women's reproductive cycle, while also using it for those who are trying to conceive or trying to avoid pregnancy to meet their intentions.
Mm-hmm. Yeah. And FEMM is very similar to that. There's also, so Amanda and I, we both teach, basically we can teach how to chart cervical mucus to identify, signs of ovulation, because obviously that's very important to fertility as well as just women's health in general. So really empowering women, teaching women to understand, what our bodies are telling us and how that plays a role in your overall health, and then treating accordingly if, there's any yellow flags, any red flags that need to be addressed, which can look, obviously present different depending on what that might be: PCOS, endometriosis, infertility, et cetera. So really getting at what is driving these abnormalities and these different diagnoses, as opposed to what women might experience in a typical doctor's visit if they were to present with these different diagnoses or different symptoms.
Absolutely. So you mentioned the approach being different than what you would typically get in a standard traditional medical doctor's office. Can you give an example of something in FEMM where you're like, this approach differs, and how it differs from sort of the standard OBGYN approach?
Yeah, definitely. Well, you and I have both gone through clinical experiences. So we've been in lots of different doctors' offices on both sides, really, as far as the healthcare side and then the patient side. So frequently with typical doctor's visits for women's health issues, woman presents with irregular cycles or menstrual pain or severe symptoms before their menstrual cycle starts. Their options might be birth control, or for heavy bleeding, irregular bleeding, it could even be, surgery. So birth control or surgery, those are largely kind of the tools in the toolbox that you might be met with if you present to a typical doctor's office. Whereas with the FEMM and the NAPRO approach, we definitely are more, I would say, aggressive. We're not jumping to surgery, and we're not utilizing birth control at all. And so we are drawing labs, and we're looking at, what do your hormones look like? What do they look like throughout the menstrual cycle? Because they change, and they're supposed to change throughout the course of the month. So what do those look like? And we're looking at the lab values with really not just the general lab reference ranges, but really an acute lens based on evidence-based research and most current research that's out there. And using that lens to, see what's normal, what's abnormal, what can we flag here, and then how can we treat that? So for instance, irregular cycles. So why are there irregular cycles? We don't want to give you a pill that's going to mask why you're having these irregularities. Sure, you might on the surface notice quote unquote regularities with something like the pill, but really what that's doing is masking your symptoms and making your underlying condition worse instead of doing any deeper digging. So by testing your labs and in looking deeper, looking for that root cause, we are looking for thyroid conditions. We're looking for insulin resistance because your blood sugar, your insulin, your thyroid, all of these things everything's intertwined in your endocrine system and your hormone system. So looking, deeper to see what is contributing to these irregular cycles and addressing that appropriately would be definitely how we differ, I would say.
And kind of along those lines, I would say that NAPRO and FEMM are very similar in that respect. And something that NAPRO uses a lot, and I feel like FEMM does this too, is to look at first trimester miscarriage and miscarriage in general as a tragedy and something worth evaluating or working up, and not waiting for 3 consecutive miscarriages before doing a really deep dive into what could possibly be going on. I would also say that NAPRO covers a lot of pregnancy management to get into, evaluating hormones early on in pregnancy and looking at what's the progesterone doing, what's the estrogen doing, what's the thyroid doing, how can we optimize things in the first trimester or even in the preconception phase going into this pregnancy to make it as optimal as possible.
100%. And you mentioned, so miscarriage specifically, because I know that that's something that unfortunately we see a lot of, and just reflecting on how terrible that is for a woman, presenting to her typical doctor's office with a miscarriage or even 2 miscarriages, and to be told that, oh, it's not an issue, come back if and when you lose another child.
Mm-hmm.
And so, yeah, obviously, NAPRO and FEMM differ from that significantly. So tell me about what specifically is your approach, to miscarriage? And obviously it differs so much depending on the patient to patient, but what are some things that you'll do, kind of right off the bat, as opposed to, if someone has to wait?
Yeah, absolutely. So typically in the literature, 3 miscarriages is considered worth working up. A lot of providers will work up a patient for certain underlying conditions if they've had 2. I typically, after 1 miscarriage, will offer a patient sort of tier 1 testing, which would be, let's look at your hormones and see how they're doing in the follicular phase and the luteal phase. Let's look at male hormones, insulin resistance, thyroid, prolactin, things that could be fairly straightforward, easy fixes that could contribute to a pregnancy loss. And then while talking through that tier 1 testing, I usually also say, and in the first 3 weeks of pregnancy, if you have a positive pregnancy test, we're going to test hormones. We're going to test HCG. We're going to watch these things rise because there's a lot of good research on low progesterone and low estrogen in that first trimester contributing to miscarriage, but also suboptimal thyroid function. So I'm pretty aggressive with thyroid, probably more aggressive than average, in part because I see that it plays such a heavy part in recurrent pregnancy loss and in optimal pregnancies. And it seems like every fertility provider has a strict thyroid parameter that is more strict than the general population. I think there's a reason for that. But then after that, I have tier 2, tier 3, tier 4 testing. There's a lot of different things that can be done, especially depending on how many losses have occurred, like autoimmune clotting disorders, thrombophilias, which would be like your genetic clotting disorders, genetic issues, like looking at recessive genes in both parents, immunology. There's a lot of different tiers of testing, and even looking at like structural problems in the uterus or infection in the uterus. There's so many different places to go. So I usually tell the patient about all the testing, because the worst thing for me would be for a patient to come to me for testing and then say, have another miscarriage, and be like, well, why didn't we do this testing? And they didn't know about it. I feel like they should know about all the testing available. And then taking a pretty proactive approach to that first trimester, because while some people will say you can't prevent first trimester loss, you can prevent some types of first trimester loss. And far be it from me to neglect something and have a first trimester loss that would have been preventable.
100%, 100%. And then how about explaining to listeners out there? So I think that, some people might be confused about, how does this fertility approach differ from something like a fertility clinic or somewhere where IVF is, their main modality?
So the NAPRO approach differs from the fertility clinic in that the goal of our approach is to get to the root cause of infertility, fix anything at the root cause that we can so that natural conception can occur. And there are definitely situations where natural conception is not possible. But in a lot of situations, if you jump from minor infertility workup straight to the fertility clinic, you've missed this large amount of factors that could be controlled or modified to allow for natural conception.
And not only allow for natural conception, but to allow for optimal health and, preventing things later on, because we're catching things like thyroid conditions and insulin resistance and things like that.
For sure, for sure. And that's the restorative side. Like you almost wouldn't even have to call it fertility. We're just getting to the underlying cause and then maybe adding some Clomid and letrozole in here to help with ovulation. But ultimately, if you fix those issues, the insulin resistance, the thyroid, hopefully you're optimizing ovulation, allowing it to occur more naturally and things like that. There's so many different factors that you can modify. And so if you leave out jumping to the fertility clinic and modify these factors, the statistics are amazing on the outcomes that could happen.
Oh, yeah. Oh, yeah.
And you mentioned insulin resistance, and I know that FEMM has a very active and proactive approach to insulin resistance. Can you tell me a little bit about what your approach would be versus what someone might get in the greater community?
Yeah, definitely. So I think a good example of this would probably be if you look at PCOS or polycystic ovarian syndrome. So with PCOS, very commonly, a large piece of that puzzle is an underlying insulin resistance of some sort. And this is also, this is very well known. And typically, even in most doctor's office, if you have a diagnosis of PCOS, they might give you metformin, which is a medication to help regulate blood sugar, help prevent and treat things like insulin resistance, prediabetes, diabetes. FEMM, I would say, goes one step farther. They're definitely more aggressive in treating insulin resistance. Now, they do that through commonly offering triple therapy. So in addition to educating the patient about diet, lifestyle interventions that are going to help the body really handle the insulin and glucose relationship better and improve health overall, but also offering, more aggressive treatment because, in the research, in clinical patient experience, by aggressively treating that insulin resistance, you can easily, repair ovulation because that's such a core piece of PCOS and fertility in general.
That's amazing. That's amazing. And what would you say is something that you see a lot of in your practice or something that has been coming up more and more lately?
Yeah, I would say in my practice lately, I definitely have seen a lot of, I guess, blanket term would be like a luteal phase defect. So luteal phase being the latter half of your menstrual cycle where progesterone is the dominant hormone, and then that comes from ovulation, which should happen around mid-cycle. So I'm seeing a lot of luteal phase defects, so meaning either shortened luteal phase or there can be a myriad of symptoms, but a lot of women might experience PMDD-like symptoms. So increased anxiety, depression, sleeplessness before their menstrual cycle, a week before or even 2 weeks before for that whole luteal phase, maybe brown bleeding, spotting, things of that nature. And that's obviously crucial to a woman's mental health, to her physical health, because that happens every month. And if it's happening to you for you're having these negative side effects for 2 weeks out of every single month, that's half your life. And then not only that, but looking through the lens of fertility, that isn't the best case scenario or optimal setting for a woman to conceive or be able to conceive. So I definitely am seeing a lot of that lately. And so really addressing, why is there a luteal phase defect and how can we treat that? How can we eradicate these symptoms and normalize anxiety and depression and menstrual cycles? Yeah. What about you? What are you seeing?
Well, I definitely see a lot of thyroid disorder. Now, maybe it's because I go looking for it, but I've seen a lot of women with recurrent miscarriage, infertility, cycle irregularities, especially women who ovulate later, who maybe don't ovulate on day 14 every cycle, who are coming up with functionally suboptimal thyroid function. And so treating those has actually really improved pregnancy outcomes. I've had some people who have had consecutive losses, birth defects that might be thyroid related, things like that, who are now getting pregnant and not having those things just from being on thyroid treatment in pregnancy. So I've definitely become a little bit even more aggressive because I've noticed recently I had one patient who had a history of loss. Thyroid was normal. And we thought, well, if you get pregnant again, maybe we'll just check thyroid in early pregnancy. And so we checked it at 4 weeks and 5 weeks. Then we checked it at 6 weeks and it took a major change. And it turns out that all of her losses had occurred at 6 weeks. And so we started her on thyroid medication at 6 weeks. And this is the first time she's ever made it to the second trimester. So is it the thyroid for sure? I don't know, but it sure was helpful in treatment. And maybe it is optimizing something that wasn't optimized before.
That's awesome. And that's obviously not very commonplace for the thyroid to be checked, really very frequently in pregnancy, much at all.
For sure.
That's awesome. And then I feel like I've seen you doing lots of bioidentical hormone replacement therapy lately. And I feel like people always have questions about that. So do you want to talk about that a little bit and what that looks like and what it even means to be bioidentical hormone?
Sure. So bioidentical hormones are hormones like what the body makes. So not synthetic hormones like what you might find in the birth control pill. And bioidentical hormones can be used at all different stages of reproductive life. I've had a lot of experience with using them in the reproductive years for luteal phase defects, for PMS, for PMDD, for postpartum depression, menstrual migraines, you name it. You can use especially bioidentical progesterone for those things. But in the menopause and premenopausal years, it becomes a lot more nuanced. Everybody's very different. There's not a straightforward approach. And so I've been using it more to treat menopausal and perimenopausal women for symptom control. So a lot of these women are having hot flashes or even blood pressure problems, skin issues, you name it, a lot of different things, insomnia. And so we will often check hormone levels if they're premenopausal and treat according to whatever deficiency is happening. I usually check progesterone, testosterone, estradiol, and DHEA and treat what is necessary there. But if they're menopausal and they're not having cycles, then a lot of times it's a daily prescription of bioidentical progesterone, estrogen, DHEA, whatever they need, at dosages that put them in a physiologic range for that hormone. So every menopausal provider is different. There's definitely different schools of thought on whether or not to check lab levels. The training that I've had does check lab levels and tries to keep them in a low normal physiologic range for women of cycling in these menopausal patients. And they tend to have a really good response. And because the doses are low, there's a lot of safety in the medications, and they're taking something that their body used to produce anyway. So there's not the concern with what might be a risk from synthetic hormones.
I feel like patients commonly there's a lot of conversation out there about bioidentical hormones, and patients commonly have maybe some misconceptions or, what are the risks of not having bioidentical hormones versus having bioidentical hormones? And this is a topic that could be a whole nother podcast, but if you want to kind of speak to that a little bit, since it's a common question that we get.
For sure. So it definitely could be its own podcast. But generally speaking, a lot of the research that is negative on hormones has been done on synthetic hormones. And when it comes to the bioidentical, while there are little localized studies, hundreds of them in many Western countries, there's not a large study for their safety or effectiveness. And the North American Menopause Society has started putting out a little bit of research on the bioidenticals that is favorable. So there is a major organization now that's supporting some of it. But generally speaking, these small studies have shown the safety and effectiveness of these bioidentical hormones as opposed to the concerns for negative effects like cancer or blood clots that might come from the synthetic that we know were part of the original very large study that gave hormone replacement therapy a bad name.
Which is very interesting because those are, the synthetic hormones are the ones that are in like the birth control pill that are being used by millions and millions and millions of people all around the world. Yet the bioidentical hormones, somehow that has gotten a bad rep over, I think a lot of people are realizing the negative side effects of the birth control pill now, thankfully. But it's just very interesting that kind of has gotten twisted in the narrative a little bit.
And I think some of that comes from the fact that you can't patent bioidentical hormones. So there's not as much research being done on them. But it's definitely helped a lot of my patients. So
definitely. Awesome. Well, I think that wraps up our conversation for today. We'll definitely have a lot more to talk about in future podcasts.
That sounds great. Thanks so much, Maddie.
Yeah, thanks, Amanda.
Thanks for listening to this week's episode. To learn more, you can visit our website at fiathealth.org. If you enjoyed this episode and you'd like to help support the podcast, please subscribe to our show on your favorite podcast platform and leave us a review. This helps make the podcast easier to find. Lastly, if you'd like to reach out, ask a question, or suggest a topic for a future show, send us an email at media@fiathealth.org. God bless.